I'll record it.
All right. Hello, everyone, and welcome to this evening's discussion on hyperemesis syndrome. Thank you for pulling yourself away from the election updates for the next 45 minutes. For those of you new to the program, I'm the CEO of Physicians Research Center Plus. We specialize in phase 2 through 4 studies. That's our clinical trial section. We have education, and that's what you're attending tonight, Cerium. It's the one pillar of PRC, and it's designed for the busy healthcare provider who wants to understand cannabis and its derivatives through the lens of science. Next slide, Jahan, please. If you have a minute, we'd like to thank you for taking time to join us today and what Cerium can offer. This is a QR code that we ask anyone to participate in so we can continually understand the healthcare provider that we service and to improve our programs. So if you want to just take a minute to scan that QR code, it should work this week. The last time we got feedback that it wasn't working, but I tested it and it should be working. So the next slide, Jayhan. So now in support of our third pillar, here's yet another QR code, but this one's a little different. This one's called Buds Info, and it's something that we put in place a couple years ago. It's to collect adverse effects um, on anyone who uses cannabis or cannabinoids. It was originally designed, or put into place because of the Delta 8, there was the increase in adverse events around Delta 8, but we collect data on all cannabinoids, so whether they're hemp or cannabis. So you can share this with your patients or anyone who's tried or uses the products so they can report, if they never had an adverse effect, we want to know that too. And if they have one with a particular product, we want to know about that. So the next slide, so you can check out our website if you want to learn more at prctrials-plus.com. So the next slide, please. So joining me this evening is Dr. Phil Malloy. He's a rheumatologist, recently retired from clinical practice in Massachusetts, but he remains very active in caring for patients and participating with PRC and Cerium specifically. Dr. Len Kamen is from Jefferson University. He's a very, very busy clinician. He's the president of the Pennsylvania Pain Society. He's a board member of the Rothman Opioid Foundation, and he's the director of Moss Rehab Outpatient Center. And certainly, last but not least by any means, is Dr. Jehan Marcoux, a cannabinoid researcher who's been working in the cannabis space for probably greater than 20 years and has a whole host of experience like across the board. I mean, I don't know if there's a topic related to this that he can't speak to a little bit. So now I'm going to hand it over to the three of them for this evening's topic of hyperemesis. I think that Dr. Marcoux may have a few announcements before we begin. So thank you.
Thank you so much. We'll have my announcement is there's some fun announcements at the end of this as well, including opportunities how you can engage and participate in different things because we are putting out articles and we'll be looking for statements from clinicians and other experts. But our journal club, the mission is to support the education of healthcare professionals with discussions of published research. We do our best to approach each paper with consistency, fairness, and transparency. So today, the papers we're going to discuss, one is a review article, and we have a bonus because Russo also came out with an article. So we've pulled the latest sort of synthesis about public health stats, about diagnosis, about prevalence, about costs of the patient, and put that all together, the background information, which will then roll into these two very interesting case reports that are interesting across medically and even legally for where and how they take place. I think they're quite interesting. But we're going to see again what you all think about these case reports and did the researchers get it right who published these case reports. So first, I want to go to a quick poll question about the topic. Here's your first chance to participate, and let's go back and relaunch this poll, or So it's just three quick questions to get us thinking. Um, so the first question is, if a new patient comes in with nausea and vomiting and a negative screen for cannabis, in this case THC, does this rule out a CHS diagnosis? Um, Two, if a new patient comes in with nausea and vomiting or has a positive screen, does this prove a CHS diagnosis? And to what extent would a negative THC screen rule out a CHS diagnosis? And the purpose of this is just for fun participation. So no need to worry like we're gonna call on you and you're gonna get a C minus if you get this wrong. This is this is just for discussion purposes. Um, Few of you have not voted yet, but we'll all give you the chance to vote. What is going on? All right. It's been out for a minute. We've got some responses, so I'm going to go ahead and end the poll. 8 out of 8 responses. Closing in 5, 4, 3, 2, 1. All right. We share the results. I assume you all can see this. So yeah, so most of us say, does this rule out a CHS diagnosis, right? A lot of people say no. There could be other factors there for why you might say yes, why you might say no, but a lot of us agree that just because someone has a positive screen for THC, it doesn't prove a cannabis hyperemesis syndrome. And to what extent would a negative THC screen rule out a diagnosis? Most people say somewhat. And I think after we talk through the literature and the case reports, it'll seem like a pretty rational thing. But interesting results. Appreciate the feedback. And moving on. So boom. So what is the problem and what is known about it? I have like a weird annotation in my my screen. Let's see if I can get rid of it. There we go. All right. Um, so this CHS syndrome is often thought of as being enigmatic. It's a constellation of syndromes. And what's interesting is that researchers have characterized it as sort of having three phases. Prodromal, so there's a morning nausea, abdominal discomfort, followed by intense vomiting, severe abdominal pain, and then recovery. Early reports of CHS that involved chronic cannabis consumption noted that the symptoms were relieved through the use of hot showers. Um, Evidence has come out that the use of painkillers, benzodiazepine, antihistamines, and even antidepressants appear to at least contributed to recovery in some patients. And so it's thought that this is increasing in its prevalence. There's more and more diagnoses of CHS. Again, and this is paralleling a rise in legalization and even CBD use. And so this is thought of as an emerging public health risk because it's one of these sort of, if you want to say, unique or true contraindications associated with particularly heavy cannabis usage in most cases. However, we feel there needs to be greater awareness about this. And again, we are still not at the point of timely diagnosis, effective treatment, or even how do we identify those vulnerable for prevention. So here are some interesting stats from the papers by Russo and Stubbs. So 9.9% of individuals who report cannabis use in the last year were daily or near daily users. Almost 90% of 205 confirmed cases, there was an average of 4 grams of THC predominant cannabis use per day. The number of people who are affected with this in the US is unclear, but estimates range from 350,000 to almost 3 million people. This syndrome is often misdiagnosed. Again, as we'll see when we talk about, this can involve multiple clinical visits, lots of different tests. And again, the average cost was over $95,000 to get to this diagnosis. And what's also interesting is that almost 80% of respondents indicated that they returned to cannabis use after diagnosis despite pain, suffering, and costs. So, again, right now, diagnosing CHS relies heavily on clinical history and trying to rule out other possibilities. Here's a quote from the Russo and Whiteley paper that I liked was any young person presenting with repetitive vomiting who admits to cannabis usage in any context may be misdiagnosed on the spot as having CHS by a clinician in too much of a hurry, such that fine diagnostic distinctions and historical details are not considered. And so one of the things now is that it's just more common. Hey, if we can associate it with cannabis, let's just do that, and we have our diagnosis. But again, it's crucial to differentiate these different syndromes, which could have very different pathophysiologies. And again, there we might find that the cyclical vomiting syndromes and cannabinoid or cannabis hyperemesis syndrome might be, well, there might be 4 or 5 different types of conditions in there related to different responses. And we can talk about that a little bit later, but it's interesting. So just a little timeline to show you how quickly this has moved. 1996 was really the first indexing of CHS. 2004, it was the first formal confirmed report in Australia. 2013, synthetic cannabinoid, JWH, that whole series of compounds was reported causing this. Those are very strong CB1 agonists. In 2018, with the Farm Bill, we also saw a rise in adverse events across the board for cannabinoids like Delta-8 and other ones. And again, indeed, in 2021, we had a confirmed case of CHS symptoms after consuming Delta-8 gummies. And more recently, we see that there are mutations that are associated with a vulnerability to CHS compared to chronic cannabis users without those symptoms. So there may be a strong genetic component. And again, if you're interested in the genetic component, it is in the Russo article. Dr. Malloy, I don't know if there's anything on that background you wanted to clear up or comment on, or
No, I would like to, yeah, I would like to mention, I think that the links to these two background articles and the two case reports, so there's four in all. So the Russo and the Stubbs article, I think you have the links. If you signed up through the Cerium website, you can get a copy. I hope most people who are interested in this topic have downloaded or printed a copy. We
That's
intentionally did not go into the proposed on a cellular and receptor level, what the theory is on how this happens. We do have emetic centers in our brainstem, just below the HPA axis, nerves in the brainstem and medulla that feed the stomach, the splenic nerve, and are associated with nausea and vomiting. They're rich in CBR1 receptors. There's animal models of either blocking or stimulating these receptors and associated with different outcomes. But we didn't want to swim in those waters too deeply. But in the Stubbs article, if anybody's interested in the current sort of overview of how this happens, in the Stubbs article, figure 2, I can't hold it up, it doesn't show, is a pretty good schema of the current understanding of maybe how it works on a cellular and nervous system level.
and we'd
Anything
be
to add to
happy
that?
to share that figure after we go through the case reports if people want to kind of walk
Okay.
through that. Happy to pull that up. And that's a
All
great
right,
point
let's talk.
about the basic research is that you can get an animal to throw up with targeted cannabinoid administration. So that is not uncommon, I think, thing to do. But again, it depends on the challenge for the animal too, what you see. So it does make it a little bit difficult to predict when it will happen.
Add this to one of the paradoxes about medical cannabis, because I know there is medical cannabis products that are used therapeutically against nausea too, especially in chemotherapy. So the story is mixed in some situations. Maybe it's genetic, maybe it's chronic use, maybe it's who knows. It's pro-emetic, and in some patients it's anti-emetic. But anyhow, let's go into the two case reports because they're both kind of interesting. So let's talk about the first one, just a few slides here. The unusual thing, oh, I think there's a typo here. In the title, it says CBS, but it should be
Oh,
CBD. Sorry about that. Um, Historically, most people have assumed that THC is the culprit, but this case report got attention because it's being proposed to be one of the first cases of a CBD only product. Now, I'm sure will have something to say about that later. A CBD only product. If you don't have the product in hand, if I was going to do research on this and collect patients, I would have them bring the product in that they were taking because it needs to be analyzed. And there's street products, and then there is dispensary products.
mm,
Dispensary products are tested, as everyone knows, by the batch and have lists of ingredients and concentrations, and street products don't. It's quite simply. So this patient presented with abdominal pain, multiple cyclic vomiting episodes. If you read the case report, it's only a two-page case report, but I won't go through it in detail. But there's an initial trip to the emergency room, and he reported that he used cannabis or CBD products at the time, um, and he was advised to take hot showers, which is sort of a mysterious but repetitive theme here that hot showers somehow benefit this diagnosis. 3 months later, he's back, recurrent, 8 out of 10 pain, did not alleviate the second time. Routine labs were normal. And I'll come back to that later, but you'd be thinking about that. What are routine labs, by the way, in the ER of somebody vomiting? Does that include a drug test or doesn't it? So he's rehydrated, given the usual stuff that is alleged to help. 6 more months later, he's back. Again, same history, on and off CBD only. This time he reports that he's been abstinent for a while, and his pain this time got better with hot showers on the third time and opioids. And then there's a fourth time. And he had the usual workup. And as Jehan told you in a previous slide, how do you diagnose the CHS? Well, you rule out other diagnoses and you take a history. Uh, how do you guys feel about that? So yes, I smoke weed here and there, and I don't have gallstones, and I don't have ulcers, and I don't have whatever. You can come up with no other cause, and I either admit to be an occasional user or a regular user, or I test positive or I don't. What do you need to be suspicious? I'm just throwing that on the table right now.
and
Phil,
we
How
did
do you
have
really?
a quick question. Someone asked about alcohol use during these events. And we're I think to Dr. Molly's point, we're these clinicians are relying on self-reporting a lot of the time. So
Right.
was a history of alcohol use, even
Yeah.
alcohol use disorder with
Yeah.
it's not
this
only
person.
alcohol, polysubstance abuse,
Yeah.
and tobacco, alcohol, what God knows
Yeah.
what else. He drinks, Red Bull and caffeinated,
Yeah.
so that's a likelihood. Now, I want to ask a question, Phil, if I can, that
Sure.
CBD is not CBD products that are pure are not often sold in dispensaries. I don't think that there is a pure CBD without THC in the medical marijuana dispensaries because you can buy that over the counter and buy it on Amazon and other places.
Yeah.
So I'm not sure that he is really fully tested for contaminants, in this case, pesticides or what have
Yeah.
you, because it isn't sold through dispensaries which are state regulated and do tend to have more of an
Yeah.
organic product base.
Yeah.
So I
Good.
wonder about that as a premise of this, that this
Yes.
is not just it's just out of the
Well,
blue.
I'm
And
I'm
the
glad you
concern,
I'm
So
glad you
in
mentioned
the
that.
right, Phil.
Thank you.
in the
Yeah.
case report, he does in one of the visits he does mention he was smoking a CBD cigarette every other day was his I think it was during the third visit. But what does that really tell you? I think yeah.
And as a footnote, we'll go on to the next slide, but as a footnote, we are considering having a 2025 next calendar year journal club, Serum Journal Club on contaminants in cannabis products. We are not sure about that. So this is self-explanatory. Everybody knows that THC and CBD and most cannabinoids are very lipophilic, and your adipose tissue is a sink for them.
And
Um,
yeah, and we can't rule out CBD on its own because that is on the box of Epidiolex is that it may cause um, vomiting as well, nausea and vomiting. So um, I think that it could
yeah,
be either way. It could be residual THC, could be a lot of THC, could be even a susceptibility to the side effects of CBD.
and and that's pharmaceutical grade CBD, pure, allegedly pure CBD. There's some evidence, I'm not going to go into it, but that you have, if you take a product orally, you have enzymes in your gastric juices that can convert CBD to THC as well, and other cannabinoids that are active. Um, there's only a few small publications about that. So we'll go to the next slide, Jayhan. So
So
yeah, the authors note that this might be the second report. 40-year-old woman, unclear if the case could have been due to some THC for several reasons. CBD, that is, first of all, if it's not in a dispensary, it's not labeled or tested, and you're not sure if it's 100% what it's alleged to be. Plant extracted CBD, if it comes from a marijuana plant, could drag some THC in with it and other active cannabinoids theoretically. And then you could be converting it. If you look at the molecules, everyone has a diagram of what CBD looks like in THC. They're pretty close to each other, the chemical structure, really, even though biologically they're very different.
and
Um,
likewise, the sensitivity to both can also be very different between individuals. It's highly variable as well.
yeah,
And there was one other CBD associated potential CHS case, but there was a huge change in diet at the time, and they don't, so it's hard to rule um, in favor of a cannabinoid hyperemesis syndrome.
all right. I think we have one more slide on this article, right?
All right, so
Yeah,
some of the
strengths and
strengths,
weaknesses.
yeah, and weaknesses.
Yeah, there are strengths to this article. To me, the strength of this article was that if you take it at face value and believe the patient reported, then here is a presumed case of CHS that's caused by CBD. Who would have thought? I mean, that was what I thought when I read it. So you consider alternate causes of the nausea and vomiting and exclude them. Um, yeah, you can read for yourself what the limitations are. In my opinion, the biggest limitation in this study is we don't have the product that the guy took to test, and the patient himself was not subject to a tox screen. That was the purpose of asking the poll questions. I mean, what if he tested positive for THC? Would you say, where did you get that CBD anyhow? Are you sure you know what you're taking? And so forth. And so
And
I
they
think
were
the lack,
running a lot of tests, a lot of blood tests and immune cell tests. So they were doing, Dr. Moore, like these panels. So it just seemed like why not check the box for a drug screen or a tox screen? Like it, yeah,
yeah,
just doesn't make. Um,
I I would agree. There's just an empty box here as to what where this is coming from. When he says he smokes a CBD cigarette, that means he's getting leaf, and you don't buy leaf CBD.
yeah,
So he's getting either off the street or from a CBD farm down the street, or I don't know.
yeah.
It's too nebulous. It's too nebulous.
So
Let
Mike,
me add one
yeah,
etiology that never would show up anyhow, which is that the possibility I think was raised in one of the articles that um, this form of emesis is a form of a migraine, and there are no tests for migraine either. They're just some, again, autonomic dysfunction and maybe, vasomotor driven, but it's, not fully explainable. And so to blame these all on the CBD with this kind of background, it doesn't bode well for the volume of cannabinoid hyperemesis syndrome that they're proposing here, 350,000. I'm sorry, I don't see that. I can't buy that figure. I think that's a
Yeah.
very biased.
Well, I would throw out to the audience who's on tonight, on joining us on election night, what kind of evidence for you to buy that this is a cause and effect relationship between CBD and hyperemesis? What do you need to convince you? What do you need? And so I'm looking at this as a possible case. That's the way I'm looking at this case right now. What do you think, Jahan?
I don't think I think it's a factor, right? And it looks
Yeah,
like right now, I would say that CBD appears to be a potentially a bad factor, or what we're calling a CBD product in this person's well-being. But is it the end all be all cause? I really don't know if they showed that. I think we're missing just
right.
some basic information that would help.
The fact that Epidiolex is associated with it sways me to give it a little bit more credibility.
Right.
So let's talk about the second case report.
I would have some objections to that because you look at any the side effect or adverse effects from hypertensives, from serotonin-based drugs. They'll all include vomiting, nausea, GI symptoms. They're ubiquitous, and every drug that you look at will somewhere down the line have GI
Yeah, good
related
point.
symptoms.
Yep. I guess
Good
you could get
point.
it from eating too much leftover Halloween candy too. So, uh,
Exhibit A.
Dr. Viner, did you have a comment? Thank you for raising your digital hand.
Oh yeah. Well, what I would go with it, even though I know most CBD isn't CBD, there's great studies that even the tested stuff has a bunch of other stuff. So the fact that it's just been called CBD, I would still worry. You got your Delta 8, there's all kinds of things. It could spray on synthetic cannabinoids don't come up in a drug screen. It'll unless you buy the expense. And they can cause CHS. There's some good cases of potent synthetic poisoning
Yeah,
cannabinoid. So I wouldn't get too hung up on, I mean, we all know it's not CBD. So the fact that there was a temporal relationship, I would still work it up and not get fooled by them calling it CBDs when we
Right.
all know it could be some. But anyway, it's
right.
a good case. I get it.
Yeah.
Yep.
It's fun.
All
It's
right.
funny. I've never seen a CBD case from, a true case was from just CBD though. All right,
All
thanks.
right.
No, thank you for sharing that. Sometimes these papers make us think it's happening everywhere and all the time, or maybe it's but it might again. It's a case report. It's not a case series. Um, so I believe we're ready to move on to the second one, which
Sure.
is a little bit more about THC.
Yeah. So this is an interesting case of of a guy in the Middle East who was traveling, and you read between the lines, and he says, "Oh, I'm going to a country, and I don't want to get caught." He's a daily heavy user of cannabis, whatever was in the product, but he admits to being a heavy daily user. But now he's going to the United Arab Emirates, and he decides to clean himself up because he doesn't want to get arrested. So he stops treatment, and then he develops impressive hyperemesis that responds to the usual treatments for CHS, including hot showers and further history. He escalated his heavy use, 8 joints a day, stable over the past 7 years. And he interrupted it 2 to 3 weeks ago because of his travel to the Middle East. And then he shows up in the emergency room. Other causes were looked at, ruled out. He saw some other consultants and specialists while I was in the ER. His treatment is spelled out, IV fluids, magnesium, antiemetics, and so forth. The diagnosis of cannabis use disorder and THS was made in this patient. He was given um, an opiate-based painkiller and the other usual cocktail that people are given. And he was discharged on mirtazapine and tramadol. And the authors are presenting this as a case that was delayed. The unique thing about this case report, if it's true and the association is true, is that there was a delay of 2 or 3 weeks between his cessation of cannabis use and the onset of his symptoms in the emergency room, which makes it kind of unusual, this case report. Is that how you read it, Jehan?
Yeah, and I included this next slide, the findings, like the second bullet point. Yeah, that's coming from the authors of the paper, that they're saying that this is consistent with existing information. Um,
Right.
and I liked your comment about reading between the lines, because he's in a foreign country where there are quite severe penalties for intoxicants, allegedly. And so maybe it's wink, wink, nudge, nudge. I stopped right before I got here. So we don't, there again, we're not really, I don't think there was a tox screen. So was maybe use of local products, maybe products he brought with him, was that still going on? Because again, if it's this is a matter of, do you take them at their word that yeah they stopped using, or um, is this an interesting case of some sort of uh, it just seems to me, it seems odd that you would develop these symptoms as you had less THC in your system, not more. Um,
Yeah.
but again, I think that I think this case really struck me as odd, and one of the reasons I liked it is it did have that legal issue associated with it, where he may not be reporting it truthfully due to legal issues. Right,
You
and
can see how a workup runs the hospital bill up. In
oh
one of your
yeah,
earlier slides, you said the average bill was 93 or $4,000, but
oh we
um,
yeah, and Megan, thank you for raising your digital hand. Would you like to comment, please?
Yes, I would. So I'm a little bit on the front lines, kind of seeing CHS, not in the ED, but just with cannabis users in general. And this is definitely a phenomenon that I've seen multiple times. Cody has seen this in the pediatric ER, that people go on vacation and then that's like their first onset of CHS symptoms is 2 to 3 days post last use of their cannabis. So it's almost like a severe cannabis withdrawal, but also like it's definite CHS symptoms. And in the survey, the large survey that we're doing, 25% of people so far have said that cannabis withdrawal has worsened symptoms and or like triggered episodes for them. So I think that's a really interesting phenomena
thank
with
you.
this.
Yeah.
In your experience, you see more. I'm a rheumatologist, and I've had two patients of my patients referred back to my office with this diagnosis from the ER. And I became convinced that they didn't have it. And I think it's almost a fad diagnosis in some. It was in the literature for a lot, 2 or 3 years ago. And it seems like if I'm in there vomiting, whether I have gallstones or ulcers or whatever, and I test positive, then that's my diagnosis, and it's carved in stone now.
Oh,
So,
yes. Oh, sorry, Megan, did you have a follow-up or
I'll just add that, yeah, I think it's misdiagnosed. I think both ways. People go years and years with like prodrome symptoms and then finally find out that, oh, it is the weed causing the issue. And they go to all the specialists, get all the workups, and it's really the weed. And then it's overdiagnosed as well. So
Excellent. And Dr. Viner, please, thank you again for
Yeah.
raising your digital hand.
I thought this case was interesting, but it really, to me, looked more like withdrawal because the withdrawals can occur a month out of stopping it. It always gets compared with cigarette withdrawal, and they try to say it's over in a week. So there's good literature that it isn't. It could be years the withdrawal. So anyway, it meets the criteria for cannabis withdrawal in DSM because if you look at his mental status, I read the whole case, so I wasn't really, it doesn't make sense really to label it CHS, but I would definitely agree that withdrawal can trigger CHS, but there's no real good differential diagnosis in his write-up, so I
Yeah.
think it's the other way around, but it's interesting. Yeah. Okay.
Thank
Okay.
you.
I would add that withdrawal is characterized by hypermotility, and that's kind of what's going on. It's a dopaminergic storm, so to speak, and that's opiate withdrawal is highly associated with that hypermotility, and
Yeah.
this is not different.
And I wonder about that with THC withdrawal because of the storage in adipose tissue and then the slow sort of um, excretion of that from the body. And that was one of the reasons why in the past it had been hypothesized why there wasn't such a severe reaction to a sudden stoppage in using cannabis products was because it sticks around so long in the body. But again, we're dealing with different form factors, with different product types, combined administration forms. So this area has gotten very complicated very very quickly. Um,
What plus the cultural from a psychiatric point of view, there's a cultural thing going on because of the different so maybe the doctors don't know DSM and cannabis withdrawal criteria because we have to take into account the psychosocial aspects of the case.
Good point.
Anyway, that's psychiatry. Sorry.
no, no, that's great. That's fascinating stuff. Um, and Phil, I think you went over a lot of
Yeah, I think
these things.
we've gone over all these, I think, now that I
Okay.
look at it.
So, um, and we've touched a lot on these strengths and weaknesses. I definitely think in some ways they provided a lot more detail than some other case reports, but in other ways, not so much. And definitely, I think this one highlights a lot of the diagnostic challenges. Um, however, I think this one suffers from, some the lack of follow-up data, and again, no toxicology screen, withdrawal from another substance or from the products he was using, and where were those products coming from that this person was using? Were they flying in to Dubai from Colorado, or were they, um, in Madagascar before this, or where were these products coming from, and what was the nature of them? I think that's an ongoing question. I think we're always interested in.
Yeah,
And
good.
yeah, all right. Um, so here is again just some more information about this again case that we think made it interesting.
Yeah,
Symptom onset after abstinence, the lack of the prodromal phase, the treatment with this antidepressant was also interesting. And we'll include a lot of this information in that FAQ that we're going to send out to attendees. Just be sure to include your email address if you'd like to receive that. I'll also try to upload it at the end into the chat. So, again, this is,
I would,
yeah, go ahead.
sorry, Jay. I would just point out mirtazapine is a antidepressant, but it's more anxiolytic than anything else. So that's maybe a part of this issue as well. It's much more and more quickly or anxiolytic than it is antidepressant. So immediate use of it is, or that there's an anxiety component to it. Interesting.
No, thank you. And again, I think this article also highlights the issue with diagnosis, potentially increasing healthcare costs. Same issues that we've been talking about with the previous case report as well. And so, so Dr. Malloy, maybe you or someone else who hasn't had a chance to speak yet, although I welcome all engagement from participants. If you wanted to finish this sentence, when it comes to CHS, healthcare providers should look the other way, take a proactive approach, ask for a certificate analysis of the product.
Do a urine tox screen.
Right. I don't know if anyone on the call wanted to jump in, throw it in the chat. Stay curious. I love that from the trusted cannabis nurse. That's great. Yeah, healthcare providers should stay curious about this. That's a great point, because this is a very interesting area, and we know now, thanks to science, that cannabis is more than THC. Took a while for us to figure that out, but now we know. And in a similar vein to this, when we talk about, addressing these sort of public health issues, these consumer or patient issues, sometimes we wonder what are the key roles of stakeholders. We know that some healthcare professionals, like the trusted cannabis nurse Megan, she has a study going on for CHS. So if you're interested in that, be sure to drop her a line in the chat, and she can connect you with that study. So we do know that healthcare professionals are doing research in this area, but should the responsibility for this fall on them? Should it fall on dispensaries, local regulators? There are some that will, have adverse events collection, but how is that used? And maybe there are other future studies or research that might be helpful in this area. I like Mark's comment here. It should be in the differential diagnosis of acute abdomen in the ER. It leads to non-needed surgery at times. It should be a board question for medical training. I like that. That's actually would be kind of amazing if that was on some certifications or board trainings about how to address this issue. All right.
So I think
Yeah.
Andrew Peterson here. I think one of the things to think about is educating the cannabis users and the healthcare practitioners about the possibility of CHS. I think the dispensaries have an obligation in some way to talk to them about this as a possibility and what the signs and symptoms might be and what to do in case they experience it. Because having somebody experience this for a couple of months, it's unfair to the patient just because they may not have the knowledge about it. And the healthcare practitioners need to, as somebody said, put this in a differential and recognize this as a possibility in a cannabis user. And they need to ask people if they are cannabis users. It's not always routinely done. So I think there needs to be more communication.
Thank you, Andrew. That is a great point. Yeah. And the comments keep coming in. Scromiting. It's a slang term. That's amazing. That is amazing.
Yeah. Can I say something? So we actually have scromiting on our survey. So it's a 2-part survey. Criteria are 18 and up, have either been diagnosed with CHS or think they may have CHS. We want them to have had their first episodes. So the goal is to get like use patterns and treatment that people have received. So the link I put in the chat is for the first part of the survey, and then it goes to the second part right after they finish it. It only takes about 10 minutes. So please pass that on if you see people with CHS. Interestingly, we are running into the same issues with our research that Russo did with his, is that the community is very, very gate kept. If you want to learn about CHS in real time, a fantastic place to do that are the online Facebook groups, because that's when you have people reporting in real time what's happening. And that's just a fantastic place to learn. However, they're extremely gate kept, and we have been shut out of multiple Facebook groups for the research that we're doing for just wanting to get this information. So it's harder to study than you would think because of a couple of people who are gatekeeping entire communities of tens of thousands of people. It's fascinating.
That's a great comment, and I've gotten some interesting comments from people when I label certain events as being hemp instead of marijuana or cannabis. And they're like, it's not hemp. And I'm like, well, I have to say that, otherwise they'll kick me off and no one can attend the event. So there are these like weird workarounds that you have to be very careful of how you're phrasing it in the language. But I really hope that eases up, because I think it's ridiculous in a lot of ways.
Yeah, it's not even like it's not the platforms, it's like the people who are facilitators and admins of these groups that are saying you can't come in here and survey this group of people. And these groups have tens of thousands of people, and they're saying you can't come in here and do that. So it's like both Cody and I have been kicked out of the largest Facebook groups for CHS.
Well, that's almost an accomplishment.
Right? I mean, a badge of honor, but also it's hindering our research.
Yeah, there's a definite struggle. So I
Yeah.
wish you the best with overcoming that. That is unfair, to be clear. Um, and just as we transition towards the end, we are a few minutes over, but it's been a fantastic discussion. We put together just this cute cartoon, kind of, based on these case reports. Just the treatment plan is just a little bit less of the cause, a little bit more of the cure, and a dash of not thinking about it. Just to be a little tongue in cheek. But it's been a fantastic discussion tonight. I also wanted to put this out there in the interest of engaging. Definitely, with the trusted cannabis nurse, I'd love to get a comment or statement outside of this from you or any of the other people who attended this, because we're writing blogs that go out to a couple or articles and other materials that go out to other websites. And we would like to write about these discussions and include diverse perspectives. And again, it's just you show up, you get to be part of creating the content. So I know I have some emails here, but if you'd like to be a source for some of the articles we write on these topics for cannabis, we would love to contact you, engage with you. Take 5 minutes to just get a comment or statement that we might be able to include if you're interested. And we would definitely tag you, put it on when we do the article. So that would be great.
All right.
And I think that brings us towards the end. Awesome. Thank you for sharing. Awesome. Awesome. I'd also want to let you know that, again, these are the first Tuesday of every month. December, we'll be exploring some new research on the munchies and sort of what is really happening there with cannabis and the munchies. Some new interesting research there. January, we'll be looking at mechanisms of THC and CBD combinations. There's been some interest in how CBD can sometimes enhance some of the effects of THC or inhibit them depending on the timing and how they're administered. In February, I go between using the term novel, semi-synthetic, manufactured, man-made, derived, partially synthetic, plant-made cannabinoids, whatever you want to call them, but people are taking compounds, putting them through a process and adding them back to plant material. And there's been some interesting case reports coming out about some of the more newer kids on the block, as it were. So we'll talk about that. And then for March, we're in discussions to do a journal club just on contamination, just reviewing some of the information about different contaminants in cannabis in association with any clinically relevant effects. So with that, I want to just say thank you so much for your time, attention, participation, your thoughtful engagement. We all really appreciate it. It's been a lot of fun. So thank you so much. Happy to answer any last minute questions or any other comments. But Dr. Malloy or Len came out. I don't know if you had any thing you'd like to close with.
No,
Yeah,
I
no,
think everyone should
go
just
ahead.
turn their TVs off and go to bed.
Yeah, exactly.
This is the best thing you'll do all night.
That's
Yes,
right. That's right. So thanks, everyone. And
thanks.
it was great that you took the time out to discuss this important topic. So maybe we'll
Good.
see you next month.
Yep, hope so.
Thanks so much.
Thanks.
All right. Bye,
Bye-bye.
everyone.
Bye, Larry. Bye.